Hello, everybody, and welcome to the Global Health Crisis Reporting Forum and our series of webinars with medical experts, journalism trainers, experts on mis and disinformation. We've been doing now dozens of webinars, at least once a week in each of the 5 languages that we're operating in. And today we have an excellent session where we're going to be revisiting one of our early sessions with Dr. Claire Standley. Thank you for joining us, Dr. Standley.
Thank you so much.
Yeah, so let me tell you a little bit about her, and then I'll tell you a little bit more about the forum. So Dr. Claire Standley is an assistant research professor with the Center for Global Health Science and Security, with a primary faculty appointment in the Department of International Health at Georgetown University. Her research focuses on the analysis of health systems, strengthening and international capacity building for public health, with an emphasis on prevention and control of infectious diseases in both humans and animals, as well as public health emergency preparedness and response. So obviously an excellent person for us to be talking about the global public health response to this pandemic and how it's varying around the world. And I just learned that she and some of her colleagues have just written a book for children on life during lockdown. So we'll also touch on that issue too. So thank you for being with us. We are, as I said, are here as part of the Global Health Crisis Reporting Forum, which in our English language forum, we now have about 3,400 members participating from across the globe. If you're on Facebook, search for the ICFJ Global Health Crisis Reporting Forum group and join it there. We're also running forums in Arabic, French, Portuguese, and Spanish with more than 3,700 members across those languages. And if you speak one of those languages, you can join one of those forums and enjoy webinars that we're doing in each of those languages. If you're not on Facebook, please visit the COVID-19 resource page on www.icfj.org, where you can sign up for newsletters to get information on upcoming webinars. Also, please visit ijnet.org, which is our go-to website for journalists around the world in 8 languages, and sign up to receive our weekly bulletin with the latest stories on journalism trends, tip sheets, and opportunities. Much of that, of course, focused on covering the pandemic. I'll also ask you to please type in your questions for Dr. Standley in the Zoom chat on the icon below, and in the second half of the program, we'll get to your questions. And thank you for submitting your ideas. If you're watching on Facebook, you can post your questions below the video post, and my colleague will send them to me. Again, this is an on-the-record discussion, so feel free to use what we talk about. And we will post both the video and a written summary of the webinar on icfj.org and ijnet.org. So let's get started. So Dr. Standley, of course, you were with us the first time back in March, late March, when much of the country, the United States at least, and much of the world was in lockdown. And during that webinar, you said, I would certainly caution governments against easing restrictions too quickly to avoid second, third, and fourth waves of infections that could overwhelm the healthcare system. Now, I'm sure you're not one to say I told you so, but what is your reaction to what's happening in the United States right now?
Yeah, it's extremely alarming. I think that the surge in cases is concerning. I think in terms of whether this is the result of lockdown being lifted too soon, what's clear now looking at the case trajectories over the past few months is that while many states were quite successful in flattening the curve, new case numbers never really dropped that low. And so what was kind of put on pause then was able to resume quite rapidly once restrictions were eased. And so, yes, we are seeing what is now quite an alarming situation. We're reaching 75,000 new cases per day in some cases across the country, and those could easily go higher if measures aren't taken quickly to reduce transmission.
And what do you think we should be doing? I should say that we're talking a little bit about the US right now, but we're going to move on to the rest of the world shortly. But what would you like to see happening across the US now?
Yeah, I think there is a need potentially to start thinking about imposing some restrictions again. And I know these don't need to be as blanket as lockdowns or stay-at-home orders, which were what was widely applied during the March situation. We have a lot more data now about high-risk environments. And so we're able to be a bit more targeted in terms of the types of restrictions that are imposed to really get at those high-risk transmission zones. So that could be, for example, large gatherings of people, particularly indoor spaces. There's an increasing body of evidence showing that masks do reduce transmission risk, even if they don't eliminate it completely. So physical distance is still important, even with mask wearing, and other such measures. And so I think there's an opportunity to really collate all of that new evidence that we've seen over the last few months and use that to determine more effective measures that could be taken.
Before the coronavirus even started sickening people in China, the Global Health Security Index released a study that assigned scores to countries based on their preparedness for a future pandemic. And with a score of 83.5 out of 100, the US ranked #1 in preparedness. But that isn't really how it worked out. What went wrong?
Yeah, I think there's a couple of different explanations that aren't necessarily mutually exclusive, so probably acting in concert. So one is just on a basic level, that particular index is largely based on things that can be measured from the outside. So often that means things that are on paper, policies, plans, procedures, things that are written down and we can observe from the outside. It doesn't necessarily speak to how those things would then be implemented in practice. So for example, in terms of communication between healthcare facilities and public health systems, there could be a procedure in place which would have given a country a positive score. They're usually binary indicators as well. So they could have received a 1 for that indicator. Whereas in fact, we found in the pandemic, sometimes those systems didn't operate as well as they should have done on paper, based on what was on paper. So I think discrepancy between what's really there and what should be there is one piece. And then I think the other piece is leadership. Management, decisive decision-making and leadership, which are things that aren't easy to capture, they're hard to measure, and weren't explicitly accounted for in the Global Health Security Index. And we've seen how that type of leadership has really been important during the course of this pandemic from the very beginning. Okay.
Let's move on to the rest of the world then. And a lot of your work has focused on Africa, where we're also seeing a rapid increase in transmission and deaths from COVID-19. What are your concerns regarding Africa's, and what can richer countries like the United States do to help poorer countries in Africa, Latin America, Middle East, Asia?
Yeah, and I think, obviously it's a very heterogeneous situation. Not every country has the same trajectories of cases or is experiencing the same thing. I think South Africa is a very interesting example where, cases in South Africa account for something like 50% of all new confirmed cases across the continent or across the WHO Africa region at least. And deaths similarly are largely being reported from South Africa. It's a big challenge. I think one of the trends that we're seeing is leaders in countries like South Africa, Egypt is another one, starting to explicitly recognize the need to reopen economies. And this mirrors language we're seeing in other places, of course, like the United States. But I think within the African context, it's particularly resonant in terms of livelihoods. The president in South Africa has explicitly stated that he needs to take people's livelihoods into consideration. And so even though he has imposed additional restrictions recently to try and curb the most recent surge in cases, there is this explicit political consideration of balancing people's livelihoods against the public health needs of this pandemic. And I think it's important to consider that. We don't want people dying of other things because they're starving or because they don't have access to ways of gaining an income. And so these are all considerations which are difficult, I think, for countries in Western Europe or North America to necessarily empathize with, but very important in some context in sub-Saharan Africa in particular. So something that we should be mindful of as well. And so again, Egypt is another one where new case numbers had stabilized after initial surges. It was one of the most heavily affected countries in the initial weeks of African transmission in February and March. And even though cases are continuing to stay stable, if not rise slightly, the government is authorizing the relaxation of restrictions specifically to mobilize the economy and is even welcoming tourism back. So again, we're really seeing this change, I think, in perception of needing to live with this virus rather than eliminate it completely.
Do you feel that here in the United States, as we're debating a new, infusion of money into the economy to deal with the pandemic, should we also be looking at how to help countries in places like this? And if so, what do they need the most?
Yeah, that's a great question. And I think, I'm a firm believer in international cooperation, particularly when it comes to global health. I think particularly with the pandemic, but we've seen it time and time again. And it's almost become a bit of a catchphrase among the global health community. Disease threat somewhere is a disease threat anywhere. We know that diseases know no borders. And so there's absolutely critical to collaborate internationally on these types of issues. And I think that that extends to financial assistance where needed as well, although it has to be done in an equitable way that promotes partnership, of course. I think in terms of the needs, medical systems and health systems take a long time to build sustainably. This isn't something that can be fixed overnight. And so some of the larger challenges like healthcare infrastructure and healthcare workforce are going to take many, many years to solve. But that process can start now, again, by working with countries to identify those needs and figure out what kind of solutions can be sustainable in the long term. In the immediate term, I think we've seen how donations of medical supplies and equipment have been very welcomed by the Africa CDC, among others. So things like personal protective equipment, testing reagents, swabs, other supplies which are largely not produced within Africa. And so African countries have been reliant on global supply chains, which have obviously been heavily disrupted by other countries demanding those resources. And so I think helping to adjust those supply and demand issues can be a really big boon when it comes to ensuring that those capacities are in place throughout the world.
You talked about the medical personnel and preparedness. Another problem I think we've seen in Africa and many other parts of the world is the brain drain. So many doctors, nurses, etc., leaving Africa to work in Europe or maybe the US. Is that a problem?
I think we come back to this during every epidemic, but also during endemic disease issues too. The brain drain is a huge challenge, and I think the solutions are far beyond my remit here, particularly, but also beyond my expertise. And there are many people that you could turn to get more insights on that. But again, building sustainable health systems, properly financing health systems, ensuring that there are well-paid and rewarding jobs for people in their home countries. All of these things can contribute to at least slowing down the brain drain and building that really positive and excellent workforce.
Yeah. You mentioned South Africa specifically and Egypt. In a lot of other African countries, the increase has not been as rapid as it has in South Africa and I guess Egypt as well. Is that because it's not spreading as much in those countries or they're not doing as much testing, or why do you think that is?
There's probably a number of factors. I think that some of the early data from countries like Burkina Faso and Nigeria, and continuing to be the case in Ghana and Nigeria, suggests that there's no reason to think that the virus spreads less rapidly in Africa. I think that's a very important thing to note, that this is the same disease. It is still very transmissible. It still has severe impacts in elderly people, and particularly those with comorbidities. I think testing is probably part of the answer. Many countries in sub-Saharan Africa may not be detecting as high a proportion at least of the mild cases. South Africa is leading the way in testing in sub-Saharan Africa, and I think that is probably contributing to the high numbers of confirmed cases that are being reported. All that being said, there's been a lot of talk also about demographic factors potentially protecting Africa and having a younger population, and that may well limit some of the severity of the disease, but I think we are still seeing, especially with the high case fatality rates throughout the continent, that elderly people and those with comorbidities are highly vulnerable to this disease. And so it is really damaging to think that Africa in some way might be protected entirely through this. And so I think vigilance is key. In terms of the limit to the numbers and the lower rate of transmission, many countries in sub-Saharan Africa reacted incredibly quickly to the first cases. They were travel restrictions and lockdowns in place far earlier than their counterparts in Europe or in North America. And I think that probably had a very proactive effect in terms of limiting transmission, and hopefully we'll see the dividends as the months continue.
Good. And I'm wondering if you've seen examples in Africa or elsewhere in the global south of countries that don't have a lot of resources, but have managed to really stem the transmission and the death rate. Any examples you can point to? And if so,
yeah, and let me just look at my notes for the exact details, because I think one that I would immediately come to mind is Thailand. So Thailand has been really praised as an example of where decisive leadership and a real community sense of participation in the response measures has led to relatively few cases and very few deaths, particularly of note because Thailand was where the first case outside of China was detected. And so there were concerns early on that this would be a real epicenter of of the disease outside of China, and that has not come to pass. Again, largely due to the Prime Minister taking action early, declaring a state of emergency, putting scientists and public health professionals at the fore of the decision-making and the response, which I think is really positive. And interestingly, in Thailand, there hasn't really been universal or widespread testing in the same way that, say, South Korea has done and been largely widely praised for. Thailand has managed this response with much more limited testing, but excellent healthcare, universal access to healthcare, affordable healthcare, and very strong contact tracing and epidemiological measures as well.
Okay. Any other examples? Any in Africa?
Yeah, so one I would just mention quickly is, and again, it's early days, so it's difficult to tell whether this will continue, but Liberia has seemed to do very well early on. Again, there was a strong centralized response. President Weah put in lockdown just 3 weeks after the first cases were detected in Liberia. There was a curfew, travel was limited between counties, schools and businesses were closed, stay-at-home orders were enforced. Even despite all these measures, there was a slight surge in cases towards the end of June, but rather than allow these restrictions to expire as they were due to, the president extended the state of emergency and the restrictions again in an effort to get these public health measures back in place and transmission under control. So I think Thailand and Liberia are both examples of countries that have prioritized the public health indicators over their economies, and as a result are seeing pretty well controlled transmission rates, at least for now.
And do you think that having had experience with other pandemics, obviously Liberia is one of the epicenters for the Ebola pandemic a few years ago, did that help them sort of prepare better than countries that maybe don't have that experience?
Yeah, I would imagine so. You know, I don't have direct experience of what's happening in terms of how those capacities in Liberia have been used. In Guinea, for example, which is a country that I worked in quite extensively immediately during the Ebola response, then immediately afterwards, I know that a lot of the field epidemiologists that were trained as a direct result of the Ebola recovery effort have been utilized to support contact tracing and case investigation in Guinea. So again, we are seeing that direct application of capacities built due to a previous epidemic for this one. And so I think it's definitely the case that there has been that utilization of that experience. I hate to encourage that parable because it makes me concerned that we'll always look to the next emergency to build capacities, and I'd much rather we focus on supporting preparedness in the interim. But I think it is important to recognize when those capacities are being used. So yeah, that's a great point.
Okay, good. One of the things that experts have always said is that the key to success in limiting the spread of the pandemic is testing, contact tracing, and isolation. Now, in the US, we've really ramped up testing, but the lag between taking the test and results is very long, can be a week or more. Why is that such a problem? And are you seeing that in other countries as well?
Yeah, I mean, it's a problem largely because one of the hallmarks of why test, trace, and isolate works is the tracing and the isolating part. So your test result tells you whether you need to be isolated or not, and also who needs to be followed up to find out whether they too have been exposed and potentially infected. And so if you have a 7-day window between taking the test and finding out the results, first of all, people should be self-isolating during that time period. And of course, the longer that time period is, the harder it is to self-isolate, especially if you don't feel sick and you don't know whether your test is going to be positive or negative. You might feel motivated to go outside if you think you're fine. So the sooner that test result comes back, the sooner you have definitive information on which to act. And similarly, if you are making contacts during those days, the longer you go out and about, the more contacts will need to be followed up, and the more likely it is that transmission occurs, onward transmission occurs in that time if you are positive. So really that data needs to be actionable, and to be actionable, it really should be coming back within 24 to 48 hours.
And other countries have been able to do that.
Yes, I was just talking to a colleague of mine who's a doctor in the National Health Service in the UK, and tests there, they're trying to a 24-hour turnaround.
Okay, all right.
It's longer in other places, of course, but I think they're trying.
Yeah. One of the biggest debates right now is whether children should be, and young adults, colleges too, should be returning to school. What's your opinion about how that should happen?
Yeah, this is a really tricky question. I don't think there's any good answers right now. Clearly, there are studies now showing that particularly among older children, so say 11 and 12 and older, there is transmission. There still is a much lower risk of severe disease among that group. But of course, there's the risk of transmission to teachers or people or individuals back in the household who may be at higher risk. So it's definitely something of concern to think about. It's so challenging also because the long-term impacts of these delays in education, as well as the societal and economic impacts that result from having children at home, are profound and I think poorly measured at this point. And protecting teachers, again, as I mentioned, is going to be critically important as well. We do have examples for how schools can reopen safely. We've seen that happen in East Asia and in Europe now increasingly. And in general, the data do seem to suggest that schools are not a major source of new transmission or new cases, particularly when precautions are put in place. And I think that's going to be a really critical point as well, particularly in places like the US, ensuring that hygiene rules are applied, masks are worn where possible. That may not be possible for young children, but at least with older children, to the extent possible, desks spaced apart as well. I think that there is an important debate about online learning that needs to happen as well. Obviously, it's not going to be applicable in every circumstance, so we cannot rely on it exclusively as an educational tool, as it will most likely enlarge existing disparities with children, those who don't have access to high quality internet or to a computer or other mobile device. But I think particularly for universities where there may be financial support to enhance online learning opportunities for some of their students, that may be something to explore as well. And I think just in general, the absolute key factor here is the level of transmission within the community. One of the reasons why schools haven't been a major source of transmission, we think, in Europe and in East Asia, although there are exceptions also, is that community transmission has been brought low through other measures. And so I think until the community is willing to take the steps needed to reduce transmission there, it's going to be very, very challenging to open schools safely. And just the very last point on that, I think, anyway, yes, I'll end there with that point and we can move on to the next question.
Yeah, okay. You yourself have young children, and maybe this is a good chance to tell us a little bit about this book you wrote, and how do you feel about your kids going to school if they're at that age? I think they might be a little young.
Yeah, thanks so much for the question. Yeah, so a couple of months ago, I was struggling to describe what was going on to my young children. So I have a 1-year-old and a 3-year-old, so they're preschool age. And I was talking over Zoom with a couple of friends of mine from my high school, actually. So we've been friends for 20 years. They're both doctors in the UK. And we realized that there was an opportunity to create a resource that would help parents gently explain what was going on and provide reassurance for our children. So we created this book. It's called Corona Who, and it's the story of a little girl called Elsie, who is based on my own daughter. And it basically follows her as she realizes that things have changed in her life in terms of some of these restrictions, and how she talks with her parents to work out how they can still have fun and still do things that they like, despite the new world that they're living in. So it's not an explainer, it's not heavy on scientific detail, but intended to just be a comforting and reassuring story. And it's available free as an ebook online. It's now available in French and Spanish as well. So yeah, I can provide the email address, the website address, and perhaps you can share it with the participants.
Love to do that. That's great, and wonderful that it's available for free online too. So let's go back to a little bit more about the spread. At one point, we thought that the virus would abate during the hotter months, at least in the northern hemisphere, and that obviously did not happen, at least in the U.S., although Europe is seeing the opposite. And then we thought we'd probably see a second wave in the fall, possibly concurrent with the flu season. Are you worried that we still have worse to come?
Definitely worried about the autumn, less due to any intrinsic climatic factors associated with the transmission of the virus and more to do with human behavior. We've seen from studies in Japan and in China that the risk of transmission is exacerbated indoors. I think one study in Japan recently suggested maybe as much as 19 times higher risk of transmission in indoor environments versus outdoor. And of course, in for example, the European summer, the weather has been very good, and so people are socializing outdoors where that risk is lower. I think think one potential reason contributing to the high rate of cases in the southern United States, for example, may be that temperatures are so high there, it's driving people back indoors into air-conditioned environments where that circulation of air may also be helping to disperse the virus in dangerous ways. And so given these factors and what we're learning about the virus, I'm very concerned about the autumn in the Northern Hemisphere in terms of crowded indoor spaces, heating systems that may not be well equipped to deal with the virus, and how that might exacerbate opportunities for super spreading events.
Mm-hmm. And obviously there needs to be major retrofitting going on in terms of the way that air circulates in our workplaces, our schools, or any place where we're gathering publicly.
Yeah, I imagine so. And I think, it's not my area of expertise, but I know that there are scientists who are working very closely on the exact specifications of those systems and understanding exactly how transmission does occur. There's still a lot we don't know about this virus. And so the more data that can be gathered on these facets of transmission are going to be critically important to designing those systems and providing effective retrofitting. And I think you mentioned the flu season. That's obviously another very important consideration, especially when it comes to things like schools reopening. How to do so safely is going to involve a lot of close monitoring and testing and assessing children for symptoms and things like that. And once you get into the cold and flu season, that's going to become much, much harder. We are going to see a greater strain on the health system from these other causes of illness, and that's going to further exacerbate the situation that we already have. So yes, these are all things that do keep me up at night.
Yeah, okay. I just want to remind everyone that please feel free to submit your questions in the chat here on Zoom or on Facebook, and my colleagues will send them to me. We're going to take your questions very shortly. In fact, let's go to one of the questions that came in ahead of time from one of our forum members, Karan Singh, who said, what is something that we thought about the disease early on that is now known to be incorrect? And what lessons does that give us in responding to future pandemics?
That's a fantastic question. Thank you for that one. So obviously, as I mentioned, this is a brand new disease. And so we're learning a lot about it all the time. And this is true for even diseases that we have known about before. Usually when there are new outbreaks, we're always gathering new information, but it's particularly important with something like this, where it's the first time that anyone's ever seen this particular disease before. I would say that one that comes to mind immediately to me is this issue of presymptomatic transmission. So based on our knowledge of other coronaviruses, and specifically SARS from 2002, 2003, and then MERS, which emerged about 6 years ago, mostly in the Middle East, the assumption early on was that transmission could only occur after someone started experiencing symptoms from the disease. And so that meant that things like temperature screening could be quite effective because you'd identify people who had a fever and therefore might be in that transmissive phase, and then you could isolate them quite effectively once they started showing symptoms. Unfortunately, as we've now seen, it seems like a large proportion of cases may be transmitted, maybe many as half of the cases are transmitted in what we call the presymptomatic phase, so before people start to experience symptoms, and maybe even in some cases without showing any symptoms at all through the course of their illness. And that, of course, has very much changed the types of measures that we're putting into place. It means that when contact tracing occurs, contact tracers need to inquire about contacts even before the onset of symptoms, 3 to 4 days. That complicates things. It's hard for people to remember where they were and what they were doing multiple days before they started feeling sick. And it also means that things like temperature screening is not going to be as effective. So that's definitely something that we've learned and has evolved in our response to this outbreak so far. In terms of taking forward to future pandemics, I think it's worth having a bit of humility about our own lack of knowledge on infectious diseases in general and how much there is still to learn. It's important to integrate past knowledge, but we can't necessarily rely on it. And I think that's a very important lesson for us.
Yeah, I think that's been one of the most surprising things, and not being an expert in this, but how different each of these coronaviruses, if they're the coronaviruses and the others, SARS, MERS, and this one, very different from each other. So, and who knows what differences we'll see in the next one. So along those same lines, what are the things that you think countries' leaders should be doing now to prepare for the future? And you mentioned this a little bit earlier about the tendency to go back after the crisis is over to sort of pre-pandemic levels of lower alerts and lower preparedness. That obviously is a concern. We need to be prepared at all times, I think, right?
Yeah, absolutely. And I think the other thing at this point, and this is particularly perhaps a lesson for those countries that have been more successful over the last couple of months in reducing transmission, the pandemic is far from over. I mean, it is still circulating wildly. cases keep going up overall on a global level. As I said previously, a threat anywhere is a threat everywhere. And so we all need to stay prepared. And that's going to be particularly challenging. Healthcare workers are facing burnout. They've been working incredibly hard for a large number of months. As I mentioned before, also supply chains have been strained throughout this pandemic. We're figuring out new and innovative ways to get those supplies to the people that need them. But without international collaboration, those systems are going to be continuously strained. And so the more that we can coordinate and collaborate and ensure that those supplies are ready for whichever country needs them is going to be highly beneficial. Looking even further ahead, I think there is a lot of talk about a vaccine and how life can return to normal once we have a vaccine in place. I find that kind of thinking a little bit disingenuous sometimes, because I think we don't know when the vaccine will come. I think the scientific evidence supporting the possibility of a vaccine is quite strong. I think that it looks likely that we'll be able to come up with some level of efficacy in terms of vaccine that is hopefully safe, but it will still take time to scale that up. It'll take a long time to distribute those vaccines equitably around the world. And so rather than looking forward to this future where a vaccine is in place, I think it's really important to also think about what measures we know work. We've seen them work in some of these countries like Thailand, like Germany, many others. What can we be doing now to realign our lives with the reality of this pandemic, protect livelihoods, keep people safe and keep children in school, but also protecting them from this pandemic?
And there's a lot of competition now between countries to develop the vaccines, in part because they will be able to, their populations will be able to access it quicker, even some espionage charges going on right now. So obviously, if that happens again, countries or continents like Africa would be left out, where they're not as likely to be developing vaccines. Is that a concern? Why do we need to make sure that, or do we need to make sure that everyone in the world has access to it, not just in the countries where it's developed?
We absolutely do. We're all in this together. And I think this is particularly acute when we're talking about, issues that the reasons why many of these vaccine producing facilities are in the global north. It resides on a long history of colonialism and exploitation of the global south. And I think just acknowledging that fact first and foremost allows us to really think about the equity of the outcomes of these types of research and development efforts. And so in my mind, there's absolutely no question that there needs to be some system for equitable distribution of these vaccines, regardless of who develops them in the first place. And it's more likely that they will be the result of international collaboration in any case. You need to have clinical trials that span different geographical settings to understand efficacy across different populations. And so those R&D efforts will benefit from international collaboration as well. The WHO is leading an effort on this already. I think that's critically important. It's the right entity to do that. It's within its remit. Of course, the US position on WHO and threatening to withdraw and formally announcing its withdrawal greatly weakens WHO's ability to provide these types of frameworks, particularly if a vaccine is developed in the US. So I think we have a crisis of multilateralism at the moment in the world, and that's going to impact the public health response. And I think it's something that needs to be urgently addressed.
Speaking of vaccines, there's also, we seem to be seeing a growing movement of people, the anti-vaxxers, saying that they don't intend to take the vaccine, and it does seem to be growing. Is that a concern, and what will that mean if we're not able to get a certain percentage of the population vaccinated?
Yeah, I mean, just on a fundamental level, I'm blown away that there's managing to be vaccine hesitancy about a vaccine that doesn't even exist yet. I mean, we don't know anything about its safety or efficacy, and people have already decided that they wouldn't want to take it. So I think that's just a sad reflection of how deep anti-vax propaganda has seeped into the mainstream of our societies. The jury is still out in terms of the science behind how many people, what proportion of the population would need to be vaccinated in order to ensure, herd immunity, and so elimination of the virus from circulating into our population, which is one potential aim of a vaccine. Models vary in terms of exactly what proportion that would need to be, who would need to be vaccinated, and it of course depend also on how efficacious the vaccine is and whether it can be administered to all groups of people or whether some age groups, for example, wouldn't be able to get it. So these are all variables that we don't know. That being said, it certainly is possible that, I think in the US, there was a survey that showed that 1 in 6 people would refuse the coronavirus vaccine if it was available now. Time will tell whether that's enough of a proportion just to impact herd immunity. Perhaps more meaningfully, though, I think especially if we're not sure that we're going to get a vaccine that fully protects against disease, even if it lessens severity, then in that case, you've got a different objective in mind. You're just trying to protect people from severe disease. And so hopefully vaccine hesitancy then would be more individual and less impacting on the community as a whole.
And this is all part of what has been called the infodemia of false information that is circulating about vaccines, but also about how the virus is spread and who's responsible for starting it. What are you seeing in terms of that? Is that getting worse? Is it staying the same, or should we expect more of it? What have you seen about that?
It's a really great question, and I don't know the answer offhand. I guess, like everyone, I exist primarily within my own echo chamber, and so I see the same, it seems to me that the same conspiracy theories tend to be circulating and continue, and I won't mention what they are because I don't want to give them any more oxygen than they deserve. I think that there are steps that are being taken. I think that your journalists and groups like yours are doing a fantastic job in trying to counter disinformation and misinformation, particularly through social media and other sources. Although it's increasingly challenging, and I think you and I talked about this a little bit before the webinar. How do you balance those concerns against free speech and other important protections, civil protections that we all strive for, and that are basic human rights as well? There's no easy answers to this, I think. And I think the more that we can continue to empower organizations like the World Health Organization to be that standard for scientific evidence and for decision making when it comes to public health, the more we'll trust in one reliable source of information.
Okay, great. Well, let's turn to our audience and see what kind of questions are coming in. So Ying Chan, who I know very well, hello Ying, is asking about supply chains. And she asked, would you be able to comment on the problem of supply chains in relation to health security, such as, would you happen to have any idea as to why the US has had a shortage of tests compared to other countries which have seemed to solve the problem of test availability?
That's a great question. I think it's a very complex system, and I'm not a supply chain expert, and there are many people out there who are. For example, Chemonics is an organization is an implementer of USAID, and they have entire teams that focus just on health supply chain issues and mobilizing resources for health. So it's really a huge issue in terms of logistics when it comes to the pandemic response. In terms of the question about the United States specifically, I think one aspect is the unique governance structure of the United States, which makes it very complicated. So there's obviously the federal level, but management of health issues is actually devolved to the state level, and in some cases even to the local authority level, so the city or the county, depending on which state you're in. And that can cause real bottlenecks in terms of supply when one state may have a surplus, but another state may actually be in dire need of swabs or some other critical reagent. And there isn't necessarily a very well-coordinated system of sharing resources between states. It can be managed at the federal level. The Strategic National Stockpile is one resource that can be deployed to provide resources to states that are in need. But one of the challenges in this particular pandemic has been the way that stockpile has been used, and a sentiment from some states that they haven't had access to the federal support that they needed in order to address some of their supply issues. In terms of also testing specifically right now in the United States, the surge of cases has completely overwhelmed laboratory capacity. So we are seeing so many thousands of new cases every day that there just aren't the resources and the personnel to conduct the tests in a timely way. And so even though testing ability was ramped up rapidly in April, May, and June, it's already being exceeded by the extent of transmission we're seeing, particularly in the southern states.
Yeah, so all of this works together. Because of rapid spread of the disease in those places, we don't have the capacity to test as many people as we need to. And again, I guess, there's a comparison to be made there with Germany, where you actually live, has not had that problem. Much of Europe has not had that problem. Even, I think, during the worst of the pandemic, testing was still happening at a much faster rate than it is here. And is that largely because of the sort of different decisions that were made in the US?
Yeah, I think there's some of it. So, And I think one country that's maybe interesting to talk about as well is the UK, which did have big problems with testing, despite having many similarities with Germany and other places in Europe in terms of the setup for how testing is managed. So I think there's a political component to it, deciding who gets to be tested and what priority you want to place on testing. And I think within the US and the UK, that priority was low at the beginning of the outbreak for whatever reason. But then, of course, ramped up quickly. And certainly Matt Hancock, the health secretary in the UK, has become somewhat obsessed with testing and has really focused on hitting testing targets. In Germany, there was a well-established system of collaboration with university and private research facility labs as well. And so those facilities were able to be recruited into the testing efforts more quickly, perhaps, than in the US. South Korea famously started using robotics quite early on, so that was able to rapidly increase the scale of testing through automation, and so no longer being limited by the human capacity of actually performing the tests. And again, in the United States, there were some regulatory delays early on. So the FDA at the beginning of the outbreak did not provide authorization for certain state laboratories to be able to conduct the tests. And so in the end, that limited their capacity to ramp up quickly. And I think now has largely been overcome, and the FDA has changed its policies, but provided an early bottleneck.
Okay. Another question here from Kunal Saikia, I'm sure I'm pronouncing that wrong, who says namaste from India. So thank you for that. How well directed and subtle responsiveness have we seen during this pandemic compared to previous experiences of handling a pandemic or an epidemic? What are the differences?
I mean, I think one of the things to note is that we have never seen anything on this scale before. This is completely unprecedented. So there's really, the rule book is being rewritten as we speak. I guess perhaps one parallel could be 2009 pandemic H1N1 influenza, which turned out, thankfully, to be much less virulent, much less pathogenic than people had feared. And so initially there were serious concerns about that being the next major pandemic akin to 1918 or some of the subsequent influenza pandemics. And so, yeah, we're seeing many of the same issues. You know, there were supply chain issues. There was a massive run on Tamiflu at the time. There were challenges with developing and equitably deploying the vaccine for H1N1. So many of the same issues are being seen now. Again, because it's a different virus, it's a slightly different global situation. It's a much more serious disease in terms of the percentage hospitalization rate. It's hard to draw direct parallels, but I think hopefully we are learning some of those lessons and can take them forward.
Okay. Another question here from Joseph Shonhiwa, again, probably pronouncing that wrong, apologies, from Botswana, who talks about, we've had cases here where a private hospital tested patients and the results came back positive. The same test was done at government labs where the results turned out negative. And talks a little bit about where those tests came from, and now Botswana is easing lockdown with minimal restrictions on movements of people from in and out of Botswana. So I guess a little bit about the efficacy of these tests, and can you get different results?
Yeah, you know, no diagnostic test is going to be completely perfect. The real-time PCR test based on nasal swabs is quite good. It's rare to get a false positive, but it is possible to get negatives. The amount of virus that people produce varies over time, even from day to day during an infection. So it is possible to get a weakly positive or a negative result. The quality of the swabbing itself can matter as well. So there are reasons why tests might come back falsely negative in particular. In terms of the antibody testing, the serology, we know that there have been challenges with the quality of the tests as well there, with some having high numbers of false positives and some having high numbers of false negatives. So in short, you know, I think we're realizing that on the whole, the real-time PCR test is quite accurate, and there's many variations on that test that are being deployed now, including some rapid test versions in different places, but they aren't perfect. And I think that's where it is important to combine the clinical and epidemiological evidence with the diagnostic test result.
Okay. Ying Chan has sent a follow-up question to the one she asked earlier, and she asked, what's the reason for the lack of capacity? Is it funding, personnel, bureaucracy, and management? all
I mean,
of
I
the
think
above?
that it depends, all of the above. It depends on which part of the system you're talking about, and it depends on which country you're talking about. It may even vary on a state-by-state level. Within the United States, public funding for preparedness has been slashed in recent years. And so that is something that we've known about. People in the community have been deeply concerned about. There have been calls to increase funding to local and state health departments for a very, very long time. So we know they've been underfunded. They don't have as many personnel as they would ideally need to conduct some of these basic public health response measures like contact tracing. And so this long history of underfunding is obviously being laid bare now in terms of the lack of capacity to mount an effective response now, or the strains at least that's being put on the existing personnel and infrastructure that's in place. And this is true in other countries as well. You know, without that investment, and it takes time, as I mentioned before, you can't create trained epidemiologists overnight, you can't create trained doctors overnight, you can't create trained nurses overnight, you can't build a hospital overnight. These are things that take a long time and sustained investment, and the more that can be developed in partnership with countries that need the support, the more likely they are to be sustainable and actually effective in the long term.
Okay, great. And we have a question from South Africa here, Antonio Kapalandanda, who's saying that the health crisis and its economic and social effects caused by COVID-19 has led to a debate about the failure of capitalism in the world. How would you explain the link between the capitalism crisis and COVID-19? That's probably a tough question, but
it is a tough question, and I'm definitely not a political scientist. You know, I think, I don't know if I would go so far as to say it's a failure of capitalism, but I think that there are some fundamental aspects of this that we've seen as underlying the public health side of it, at least. And I think universal health coverage is a big part of it. We've seen throughout the world that access to affordable, equitable, and effective high quality care is going to be critically important for all diseases. And the more that those robust systems are in place for any disease, the more they're able to be resilient to a pandemic threat like COVID-19. So again, of course, you can have universal health coverage in a capitalist system. Many do. Of course, social capitalism throughout Europe still is aligned with universal health coverage. But I do think that there is that emphasis on social services and supporting people who are most vulnerable is critically important.
Okay. That kind of gets to another question I wanted to ask, which is about, you know, for the journalists out there, what are some of the undercovered stories? What are the stories that you think we need to do that you're not seeing as much as you would like?
That's a really great question. You know, I'm seeing bits and pieces about the impact on other diseases, for example, but mostly I'm seeing reports coming from WHO or the Global Fund, or kind of the key health stakeholders there. I'd be really interested in a more holistic picture. I'd love to understand how people are being affected by the pandemic, and more than just sort of the odd story coming out of, you know, overworked parents in the United States or something like that. But, you know, when we talk about the poverty that's being exacerbated by restrictions in South Africa or Liberia, what does that actually mean for people on the ground? And what are the ways that people in countries that have been affected can see ways around this? You know, as I mentioned before, I think we do need to think about living in a world without a vaccine, at least for the next foreseeable future, probably well into 2021. And so how can we reconcile socioeconomic interests with protecting public health? And what are the solutions from the people who are experiencing this firsthand? And I think those are things that I would love to learn more about and see if there are ways the public health community can contribute to those conversations.
Okay. Next question goes to sort of the source of the disease. You know, probably more for a virologist, but let's see if you have any thoughts on it. How far is the research going towards finding the source and origin of the coronavirus to prepare for future outbreaks? Can animal trade and slaughter be reduced at least? There are thousands of theories about the probable cause. And is it important to investigate the cause to stop the spread of viral pathogenic disease?
Yeah, so I think it is important to look at the cause. You know, we know that the earlier that a disease epidemic and outbreak is detected in humans, the better chance we have on reducing transmission and limiting the scope. And that goes to stopping it spilling over from wildlife into humans in the first place. And so encouraging behaviors and practices that limit that spillover is one way to prevent future epidemics like this, for sure. And so in that sense, yes, I think it's very important to investigate the cause. At this point, my understanding is that it does appear that this novel coronavirus has a zoonotic origin, so it did probably originate in animals. We don't know how long it's been circulating in humans. We don't know exactly when that jump from animals to humans first happened, or whether it happened maybe more than once, and that's one of the reasons why it seems to be so transmissible. It may have happened longer ago than we previously thought. Most other coronaviruses are in bats originally. We don't know, again, if that's necessarily the case for this one, but it would follow the pattern set by SARS and MERS, among others. And it's likely that there would be some other species that may have served as an amplifier in between. So with SARS, one theory is that it was civet cats that were an amplifier of the virus, and it's possible that a similar situation happened here with this novel coronavirus. But I think it's important to note that there actually isn't any direct evidence that the wildlife trade is implicated in this transmission event. Early theories pointed to this wet market in Wuhan as a source of the outbreak, but later investigations have suggested it was probably more just the site of a super spreader event where lots of people were coming together rather than the source of the outbreak, or that animals from that wet market contributed in any way to transmission. So I think those are really important points to make, and we do need to tread carefully. Obviously, illegal wildlife trade has repercussions in many spheres. It's damaging to the environment, to biodiversity as well. It can contribute to other illicit networks as well. But I think we do need to be careful about condemning something before we have all of the data to support it.
And it can lead to sometimes false accusations against people who perhaps had nothing to do with the spread of the disease, but get blamed for it. Yeah. Another question that we had in advance was from Rashid Sakai. I'm not sure what country that is. And we talked a little bit about this earlier, about the potential for a second spike. I think the question here is, are we now in the second wave as a result of lifting the lockdown, or is this not what we've been expecting in terms of another resurgence of the virus?
I think it's important just to note that epidemiologically speaking, there isn't much difference between, a spike in new cases versus a second wave. It's really just a matter of scale or how you want to define it. What we're seeing is what's expected. You put in strict public health measures, you reduce transmission, those restrictions are lifted. There's still cases in the community. With the restrictions lifted, those cases have opportunities to transmit further, and so you get a resurgence of cases. It's just a very simple equation in terms of the amount of contact people have with each other, how quickly those cases are identified, tested, and then isolated, and how well those contacts are traced. So again, it all just comes back to those basic public health measures which we know are effective, and the extent to which public health authorities and government authorities are willing to reimpose some of those more stringent physical restrictions, such as shutting down businesses and schools, or reducing public transport, or imposing curfews. Those are other measures that can be added to this basic core set of public health measures to further reduce transmission.
And another question from the forum. The coronavirus has become a very contentious issue between the US and China. While international collaboration is absolutely critical in combating the pandemic, do you see possibilities for the two governments to collaborate in this common fight?
I desperately hope so. And I think, what's important to note is that even when there's tensions between the governments of countries, what happens between individual scientists can often be very different. And so there are long-standing collaborations between even the public health authorities between the US and China. The US CDC and the China CDC have a long-standing relationship. The US CDC has worked closely with China on building influenza preparedness response capacity, for example, and helped address diagnostic capacity in some of the very labs that were instrumental in first detecting and isolating the cause of this new pandemic. So I think there's really successful examples of past collaboration scientifically between the US and China on this and related pandemic prevention and response issues. And so in my mind, there's no reason why that can't continue.
Okay. Great. Obviously, though, a lot of the collaboration that used to happen at the WHO is in danger of not happening with the U.S. withdrawal. And you mentioned before that's a very serious concern, but you still think there are avenues for collaboration aside from that?
Yeah, no, absolutely. And I think, the WHO has a very important role in coordinating some of these larger scale studies and providing overall guidance. But much of the basic science that happens between individual research institutions or even individual scientists happens independently of WHO or these other multilateral organizations. These are direct relationships, or they may be part of a consortium like the influenza networks that have existed around the world. And so there's many other mechanisms for that collaboration. I do still think it's very important, though, to have that overall oversight from a body like WHO, which helps to define what research questions are the highest priority, helps provide a forum for sharing those results, although of course traditional routes like academic papers are important as well. And increasingly we're seeing information being shared through preprints, which is I'm sure a slightly mixed blessing in some ways. But there are many ways to collaborate otherwise. And I hope that those relationships between individual scientists form that kind of bridge of health diplomacy that can continue scientific collaboration.
Great. Well, I think that's a great place to end our discussion. I want to thank you so much, Dr. Standley, for being with us a second time. So much has changed between the first time we had you on our webinar and now, and I feel like I've learned a lot during the session. I'm sure a lot of people have as well. So thank you so much for being with us, and we'll continue to check in with you as things change over time. I also want to thank all of you for joining us for this webinar and encourage you to stay tuned for webinars that we have in the weeks to come. Among those, we'll be doing some webinars on the anti-vaccine movement and disinformation around it. So stay tuned for that. We have webinars coming up on diversity in the newsroom with our partner, the Media Diversity Institute, the importance of making sure that newsrooms are reflecting their communities. So that one is another one that's coming up. Just go to the Global Health Crisis Reporting Forum Facebook group and click on events, and you'll always be able to see what webinars we have coming up. So again, thank you, Dr. Standley. Thank you to all of you. Stay safe, everyone, and we'll see you soon.
Thank you so much. And thank you for the great questions. I really appreciate them.
Absolutely. Thank you.